So, hello everybody. You see that I'm really excited. I think Errol is the same. Welcome everybody to this exciting webinar. First of all, I would really thank you, the ERS, for inviting us to present the new evidence-based guidelines for asthma diagnosis in school children. And especially also for you, Ali, that you help us in this webinar. Thank you very much. Dear colleagues, you are actually amongst the first to see these guidelines that have been online since approximately a week or so. So this is really an enthusiastic thing that it's really fresh from the press. So nobody else has seen it on the screen yet. I would also take the opportunity to thank you, Errol, for the fantastic collaboration. It was an enormous pleasure to chair this task force together with you. I think we all learned a lot. It was really, really nice. I just have some housekeeping items. If you want to have to add a question, you are all muted, so you cannot just speak up. You have to use the chat function. Do you see that on the bottom of your screen? And you have two possibilities in the chat. One is participants and one is panelists. Please use the panelist part so everybody can see your question. There is also some questions that will pop up. So we do a poll, so we can actually answer the poll as long as it's popping up. You can answer that for like 30 seconds. And then we will look at your responses. It's not an exam, it's just adding to the discussion. So we will have time for discussion at the end, and please discuss with us. I think there's a lot of interesting conclusions in our guidelines. So please write in the chat your comments, what you think about, and we try to answer as many questions as possible. We will also present some slide cases if we have still time, so we can go through some clinical cases and learn about how the algorithm works, but this is if you have still time. So, my name is Alexander Möller. I am the head of respiratory medicine at the University Children's Hospital in Switzerland. First, I would like to show you the composition of this task force. The chairs were Errol and myself. We had, you see that on the left side here, librarians that did all the hard work to look for the publications. We decided to use a core group because the guideline development is an enormous work and you cannot do it just in 2 persons. So in addition to ourselves, we had Claudia Kühni from Bern and Stephen Turner from Aberdeen as a core group, and they were supported by junior members from Switzerland, from Bern, from Zurich, from England. So these are the juniors that did a whole lot of work, and we are very, very grateful for them. We had, very importantly, people from the European Lung Foundation, and we had even more important people, parents involved in our guideline development, because if we are not involving parents, we might just do the wrong things as doctors. We had ERS methodologists by the side. We had to learn a lot on how technically to develop and grade and do all the work. So we are also very, very grateful for the help of David and Tommy. And we had the whole task force that is a panel of international recognized asthma specialists. That was Bart Rottier, Giorgio Piacentini, Christiana Lex, Angela Zacharisiewicz, Fabio Medulla, Oz Gilmas, Mike Thomas, Jane Lucas, and Mirona Kutaki. So this is the composition of the task force. There were some more parents involved, but I couldn't fit them all together in this slide. So this is the path of how these guidelines went through the time. So the decision was taken at the ERS 2016. We sat together with Aaron, said we should do something for asthma diagnosis. Then we have an application to the ERS. The task force was granted. We had several webinars with the ERS team. Then we had multiple telephone conferences to define the tasks and the PICOs, which will be presented by Errol. Then we had the first head-to-head meeting in Zurich. Sometime later, we did all the reading, all the selection of the literature. We discussed the first findings at the ERS 2018, then went to the grading, the drafting of the recommendations, which we discussed a lot. Each publication we included was a long time discussed in a head-to-head meeting in Leicester. Then we did several Delphi rounds to find the conclusion that we had the recommendation ready. And then the big task of writing the manuscript started after ERS meeting 2019. And then we finally submitted the manuscript in November 20 and had the feedback in January and resent it. And very soon this was accepted and also now endorsed. So this is the long path from birth to publication of this big piece of paper that will now be presented by Errol. I have one question. So I'm not sure, I think Ali will bring up the poll. So what is asthma, or how is asthma defined? First answer, I don't know. Second answer, I think we need a task force. Third answer is asthma heterogeneous disease and there is no definition. Or simply asthma is defined by wheezing and cough. Or asthma cannot be defined in one single sentence. So what is your opinion here? Please vote, and we close the poll in a few seconds. Very good, very interesting. So this is actually what we also started with. So before we could develop the guidelines, we had to discuss between the task force at the Zurich meeting if we have an idea of a common definition of asthma. So what we actually proposed is that is not one sentence, it's two sentences, and it's two complex sentences. So we defined that asthma is a disease that includes symptoms of wheeze and cough and breathing difficulties. So this is the history, together with reversible airways obstruction, airway inflammation, and bronchial hyperresponsiveness. However, because asthma is a heterogeneous and variable condition, and frequently not all of these of the above mentioned problems are present in each individual patient at the same time. So it's a complex definition, but we believe that this is covering most of the aspects of asthma. So now the word is yours, Errol.
Thank you very much for the kind introduction, Alex, and thank you to the ERS for supporting this task force. A very warm welcome to everybody from me too. And my name is Errol Gayard, and I'm a respiratory pediatrician working in Leicester, UK. And I have some disclosures. If I could move the slides, but let's see, let's use this. Okay, just one disclosure. And I will, in the next session, try to explain the background and the motivation behind these clinical practice guidelines. And I will touch on misdiagnosis and its consequences. And of course, we appreciate that diagnosing asthma in children is a challenge. And to me, the key question is, does it matter? Because that's the key. And I will touch on potential barriers to using more objective tests in children. And then, of course, I will explain the diagnostic algorithm. So my key messages this afternoon are: diagnosis really matters to families and for the child. And diagnosis without objective tests is frequently wrong. So we need objective, evidence-based tests, and quality spirometry, bronchodilator reversibility, and FeNO are the first-line tests that this task force recommends. So I have a few questions just to understand a little bit the practice around the forum. So Ali, please, if you put up the fantastic. So really good to see that many of you are already using certainly spirometry, BDR, and about half of you are using FeNO, and maybe a quarter peak expiratory flow. So just for a little bit of context, about 1 in 10 children in the European Union are expected to have asthma, and that is based on epidemiological data. And that would mean there would be approximately 5.5 million children in the European Union with asthma. Now, here are some data on misdiagnosis. And I will explain this, how these studies come to these conclusions. So to come to underdiagnosis, I have only included studies here that include children and only studies from Europe. And investigators essentially, they usually work with schools, but several hundred or sometimes thousands of children. And these children are sent respiratory questionnaires. And when analyzing the responses where the investigator thinks the child may have asthma, these children get invited to a laboratory, they get objective tests, usually spirometry, bronchodilator reversibility, and also challenge testing. And at the end, the team decides who has asthma. And then these children are approached again, and the question is asked whether they knew about their diagnosis of asthma and whether they're under medical follow-up. And then the rate is calculated, and this is where these underdiagnoses figures come from. So, and you can see what they are. They're not insignificant. And of course, for overdiagnosis, it's a reverse process. Primary care, usually practitioners are approached, children are selected, tests are again done. These are children that are already defined as having asthma, and then based on the tests, the team then concludes that some children don't have asthma. And this is really where the data for overdiagnosis comes from. And as mentioned, these data really are not insignificant and affect large numbers of children. So I would like to ask you, before I move on, how concerned you are about misdiagnosis of asthma in children generally or in your own practice. Okay, that is very interesting, and it looks like you are sharing the concerns of the task force when we started out, that asthma diagnosis in children is a problem, with over half of you saying you are very concerned. So what are the consequences of misdiagnosis? Well, to begin with, overdiagnosis. Clearly, these children are prescribed inappropriate treatments, and these treatments, say inhaled corticosteroids, of course, have side effects. And these inhalers are not cheap, so there are increased healthcare costs. But maybe one of the most important side effects is that in many children, the real diagnosis will be missed for some considerable time, and these children have a poor quality of life with ongoing morbidity. Underdiagnosis. I think this often results from a sitting on the fence, where the doctor is not deciding whether the child has asthma or not, and no further tests are undertaken, and this often festers for quite a long period of time. And I consider this as a real problem, because this approach leads to poor medication management, poor quality of life that has been demonstrated, greater absence from school, and of course, a greater risk of asthma attacks. But by using this approach, very often children are already funneled into the use of inhaled salbutamol, because that's often prescribed. They don't take their regular medication because they haven't got a diagnosis, and it just sets things up very badly. So in addition, of course, there is a patchwork of diagnosis, and this is some data that we have been gathering in Leicestershire, working with 10 practices, Leicester City and Leicester County, and working with over 600 children. What you can see is the practice makeup from A to J. This is the 10 practices, and I've highlighted in the red the numbers on the asthma register. And what you'll see, this is for the whole population, but this is also true for children if we subdivide it. Clearly, there are fewer patients on the asthma register than we would expect from epidemiological data. And what I also invite you to look at is the variation between practices. And this is concerning because some of these practices have very low rates of asthma diagnosis, and the one on the right has a deprivation index of 1, which means it belongs to some of the highest, or the highest deprived centile in the UK. And I'm very worried about these children, because this deprivation has already additional risks attached to it. So the correct diagnosis in children really does matter, and the sense of importance is the absolute key motivation to using objective tests. And I would also like to ask the question, who decides whether it matters? Is it doctors, is it parents, carers, or is it the children themselves? So one of the motivations, as I mentioned earlier, to starting this task force was to overcome some of the barriers to more objective testing. And clearly some of these barriers relate to money and priorities. That is always the case in most health systems, and therefore the matter question is so important. If you probe people as to why not more tests are being done, this to me are the 4 key answers that come back to me again and again. Most children grow out of their asthma. Performing spirometry in children is really difficult and we can't do it. And if you ask a little bit further, they'll say, but actually asthma is a clinical diagnosis anyway, and international asthma guidelines do not recommend objective tests for the diagnosis. And when you probe a little further, then often the answer comes back, well, but in the end, nobody dies. So let's explore these. I like this, and I'm coming back to this article by Roda from 1996. It's 21 years old, but still tells a story which I think is true today. And some of the story is, and in fact, this was a pretty scathing review of pediatric asthma care. And it basically says there's still a common belief that airway obstruction in childhood is reversible. Goes on to say that although many children become asymptomatic at school age, asthma frequently recurs in adulthood. And I would add to this that there is ample evidence that children, especially those with allergic asthma, have persistent airway inflammation even when they become asymptomatic. They have lower lung function than healthy peers, and often children then enter into this teenage gray zone, especially those without diagnosis, manage their asthma, which is often not managed by the doctor using inhaled salbutamol, and this is really a high-risk group. Feasibility of these tests. We're back to the implementation study with the 10 practices we did in Leicestershire. And you can see in the red is the FeNO graph, and in the blue, the spirometry. On the y-axis, we have the percentage of children able to perform the test. And this is really at first go. And on the x-axis, the age. And what you can see is that almost 80% of 5-year-olds managed to do spirometry at the first attempt. The practices had a little bit of training, but not a huge amount, not one that could be done at practice level. FeNO has a slightly different problem and actually is more difficult than spirometry in the younger age groups. So what do current international recommendations say? Well, GINA is very clear that asthma should not be diagnosed on symptoms alone. And the British Thoracic Society guidelines, those are guidelines that we refer to in the UK, but because they were one of the first guidelines for asthma, they're still used internationally by many. And when you ask people, they will say, well, this guideline says essentially that asthma is a clinical diagnosis and no tests are needed. But actually, I have proof that this is not the case, because this is the diagnostic algorithm from the BTS, and this is taken from the last iteration of the guideline. And you can see it has 3 pillars. The one on the right, low probability of asthma, these people go on to have further tests anyway. And then there is this middle section where it's really not clear whether the symptoms are asthma or not. And there it says very clearly, perform spirometry and bronchodilator reversibility. And even if the doctor decided to always go down the left-hand panel of high probability of asthma, you can see that they may be able to start treatment, but there is a requirement to objectively assess the response. So you actually cannot enter the diagnostic algorithm without receiving some objective tests. And I think that's really important. A word about peak flow. There really is no evidence whatsoever to support one-off peak flow measurements to diagnose asthma with or without bronchodilator reversibility. And that is a very important point because peak flow remains a frequently used test due to its simplicity. So nobody dies. This is WHO data in children, asthma deaths. Many European countries are on this graph. And whilst the numbers, of course, are lowish, and clearly nobody wants big numbers of children dying from asthma, every single one of them is tragic because nearly all of these deaths are preventable. And that is really important to bear in mind. And that's been shown in the UK by the much cited National Report of Asthma Deaths. This is a panel of people looked at all the UK asthma deaths in 2012. And for children, they concluded that the majority were considered to have mild symptoms and mild asthma. Nearly all of them could have been prevented, and almost none were reviewed by their doctor in the last year prior to their death. And now coming to families, because that's really important. We're meant to ask the public about what they want. And so I put this up. This is again from our study in Leicestershire. And you can see an overwhelming 90% of families welcomed these tests. And there is some statements here as well, where parents were really grateful to have objective breathing tests to confirm the asthma in their children, and healthcare practitioners also found it very useful. So this was really the motivation that got us going to develop the first evidence-based clinical practice guidelines focused on asthma diagnosis, and especially focused on children. And again, I think this is really important because children often disappear in adult guidelines. So Alex already mentioned how the task force evolved, and I will briefly mention that patient representatives were there, pediatric pulmonologists, primary care was represented. We had an ERS methodology team to support us and junior members. And we formulated 9 relevant PICO questions, and these are symptoms, trial of preventive treatment, spirometry testing, BDR, FeNO, peak expiratory flow, allergy testing, and indirect and direct bronchial challenge testing to essentially evaluate their value in diagnosing asthma in children. We conducted 9 systematic literature reviews, and we had task force subgroups who were dealing with these reviews. Papers were selected, and there were cases where it wasn't entirely clear whether to include them or not, and these were brought to the whole task force to make a decision. And we used the QuADAS-2 tool, quality assessment of diagnostic accuracy studies, for each paper to evaluate the risk of bias. And finally, we used the overall grade approach, which is a transparent framework for developing and presenting summaries of evidence. And GRADE really is the gold standard for clinical guideline development. It's a very robust method, assesses the certainty of the evidence and the confidence in the strength of the recommendation. Finally, when we had all the results in, we had to decide on a sequence of investigations. And this was done using a consensus approach, initially face-to-face meeting, and then an initial algorithm was constructed really based on test availability and acceptability. And in the end, this was refined using a modified Delphi exercise involving the whole task force. Right. 3.5 years later, this is what we've come up with. Clearly, at the top are children presenting with symptoms, and you can see that spirometry is the first test the task force recommends. And then we're going down either the right-hand panel where spirometry is normal, or the left-hand panel where spirometry is abnormal. Bronchodilator reversibility should be the next test. And if that's positive, asthma is confirmed. Now, I'm not going to run through the entire algorithm bit by bit and piece by piece because it is online, and I will highlight certain sections in the next slide, because those that are UK based or those that are familiar with the UK NICE asthma guidelines will recognize that there are some similarities. Now, the UK NICE guidelines, there were guidelines for adults and pediatrics, but they used a similar approach and also the grade methodology. But there are 2 key differences between our guidelines and the NICE guidelines. There are others, but 2 are key. One is that the FeNO cutoff is lower at 25 parts per billion, and I will explain in a minute why that is. And there is a recommendation by the task force to perform challenge testing in children where the diagnosis is unclear after initial testing, essentially spirometry, bronchodilator reversibility, and FeNO. So I'll provide a brief algorithm summary. So the task force represents these first-line tests that I just mentioned. Peak expiratory flow variability, we decided, can be used if first-line tests are inconclusive, and that is the next best test available in the relevant healthcare setting. But the task force recommends to arrange direct or indirect bronchial challenge tests if the diagnosis remains in doubt. And I would like to stress that there is no support for clinical diagnosis alone, no evidence for a trial of preventive treatment based on symptoms improvement alone, and there is no evidence to support allergy testing. So, spirometry and Bdr testing. The task force recommends to use Global Lung Initiative cutoff values for FEV1 and FEV1 over FVC. That's really important. And the task force recognizes that spirometry has low sensitivity. And that is what frustrates, I know, many people, because often in children with asthma, when they're stable, the spirometry will be normal. But where it's abnormal, specificity is really good. And the key here is really repeat testing, and particularly when the child is symptomatic. The task force recommends to perform BDR when FEV1 or FEV1 over FVC is lower than the lower limit of normal, and we recommend a change of 12% in the FEV1 as a positive test. I have to stress there was no data to support this in children, and this is somewhat extrapolated from adult data. Now, for those of you who wonder how we got to the cutoff of 25 parts per billion for FeNO, this is based on a sensitivity and specificity analysis that is seen in the right-hand panel. And we use the Udens index to decide which the best cutoff might be. The astute of you will spot that there is also a Udens index of 38 at 19 parts per billion, and we discussed this reasonably extensively and conservatively pitched for 25. Peak expiratory flow can be done as an objective test, but the task force recommends against peak expiratory flow testing, variability testing. This is a 2-week diary as a primary test. Direct bronchial challenge testing, the task force recommends methacholine because there was no data for histamine, and usual cutoff of PC20 less than 8 milligrams per mil. Indirect challenge testing, the task force recommends a bicycle or treadmill test, and we chose a 10% cutoff, which is slightly different to some reports in the literature, but based on the review we did, we thought 10% was the right number. And we didn't think mannitol was the ideal first test because it's unpleasant for children very often and often not available. So my conclusions are that the correct asthma diagnosis in children does matter a great deal to families and children. The task force recommends spirometry, bronchodilator reversibility, and FeNO as first-line test for all children under investigation for asthma in all European healthcare settings. And direct or indirect bronchial challenge testing should be done in all children where the diagnosis remains unresolved after initial investigations. And before we throw this over to, first of all, case discussions and then question and answers, I would like to have this slide. And it really is very important to ask the question what families and children would want. We recognize that this is a major shift in clinical practice in many healthcare settings, and we're also aware that there is the small matter of a major deadly pandemic out there which complicates matters. But I would really like to highlight that all the patient representatives involved with these guidelines, recruited through the European Lung Foundation, wanted to see objective tests to confirm the diagnosis. And I think that is a really important message. Right, leaves me to acknowledge a wonderful team. It would have been absolutely impossible to produce this piece of work without the help and the dedication of so many people. And we have the task force members on the left-hand side. You can see there was a good number of patient representatives, including one patient also, the European Lung Foundation, and of course, people, unsung heroes behind the scenes, the librarians that did all the literature searches. So thank you for your attention.
Thank you very much. Ali, do you wanted to say something? No. Thank you very much, Errol, for this very nice overview, and hope everybody could understand our motivation for developing these guidelines and the whole work we did. There are quite some questions and comments in the chat. I will go through them just in a minute, but I think we have time before discussion to go through some cases to illustrate how we could use the guidelines. So this is a child, a girl that has been referred to my clinics with a suspicion of asthma. At the age of 1 year, she has her first wheezing episode that was followed by multiple episodes associated always with colds over the next 3 years. And then it became a little bit better, but the year before the referral, she again developed recurrent episodes and she was hospitalized. So she reports the following complaints. When she has a cold, she develops shortness of breath associated with a dry cough and wheeze and some retractions. And she herself asks for salbutamol because she learned with the time that it will help her. And she, however, she did not report any symptoms when she exercised. And she was already treated with fluticasone by the GP, and the mother suffers from asthma and pollen allergy. So this brings me to a question. I think I have to get the right to move. Yes. So what is your conclusion? Respond 1 is the girl has a diagnosis of asthma, or she actually suffers from a recurrent viral wheeze, or we need to perform objective tests, or let's do a treatment trial. So what would you select now based on Errol's talk? I think we can move on. Very good. I'm happy to see this result. Very good. So we did objective tests. We did a lung function, and we did also a FeNO measurement. So she had a slightly, just a borderline FeNO according to our guidelines, and it's a totally normal lung function. I'm really sorry about the numbers on the left side panel. I think there's something was missing here. So child with clear symptoms of asthma, with slightly elevated FeNO, with normal lung function. What do we next? Girl has the diagnosis of asthma. Let's do a treatment trial with inhaled corticosteroids, or we should perform an exercise challenge as an indirect challenge test, or let's do a metacolon provocation test because this is a direct test, or should we perform a 2 weeks measurement of peak flow? Please give your answers. So if you're ready, very good. So why shouldn't we do an exercise challenge? As I said, the child didn't report any exercise symptoms. And if you read the guidelines, this is actually one of the questions in the chat, based on what we should decide which provocation test we perform. So what we propose is in a child with typical exercise-related symptoms, we would prefer to do an exercise challenge. In a child with the absence of exercise-induced symptoms, report of exercise-induced symptoms, we probably would prefer a metocalain provocation. And this is what we did in this child. So if you see now the algorithm, you see it performs spirometry. This was normal. FeNO measurement, this was slightly elevated. So we went to do the exercise channel, the metocalain test. And sorry about here the numbers, but the child showed the severe bronchial hyperresponsiveness. So we confirmed her diagnosis as asthma. I think we do a second case, or agree, Errol?
Yes, I think so. We have time. We have 5 minutes.
Okay, so this is a boy that is 13 years that has been also referred for investigation of asthma to our clinic. His complaints were exercise limitation with symptoms of overinflation, chest oppression that occurred after like around 4 to 8 minutes of exercise, and reports some wheezing sounds, but no cough. And he's a hockey player. And he suffers from hay fever symptoms to grass pollen, and symptoms are more severe during the pollen season. And he was treated with formoterol budesonide and leukotriene antagonists before he was referred to the clinic. His lung function was a little bit difficult because he didn't cooperate very well, but it looked more or less normal. You can think about whether you can accept this lung function measurement, but it was not like really able to perform better. His FeNO was not elevated. So what's next? Should we perform an exercise challenge? And this is an interesting discussion, actually. So if you look at the algorithm, we would miss that arrow that goes to the left side again. But if you read the text, you see that we also propose to do an exercise challenge or a challenge test in children with normal FeNO. Consider an alternative diagnosis, or the boy has a diagnosis of asthma, or should we repeat lung function after 6 weeks of inhaled corticosteroids, or should we do a metocalain provocation test? Very good. Actually, if you look at the algorithm, if you just go to the algorithm, then this child would actually go into the part of also considering differential diagnosis, because lung function is normal and FeNO is normal. However, also the audience is right. We have children with non-atopic asthma. So these children have often normal FeNO values. However, this proportion in the school-age children is not very high. So we think it's important to also think about, consider differential diagnosis. However, you were right in responding to the question, because we actually performed an exercise challenge with this boy. And I think you don't hear the sound, but he developed a severe inspiratory stridor. And we performed lung function tests after the challenge, and there was no change in FEV1. So his diagnosis was no asthma, but inducible laryngeal obstruction. So yes, this child has a type of history of asthma, normal lung function, normal FeNO, and no asthma. So this is why we think it's important to think about alternative diagnosis in this type of children. I think you decide, Errol, if you want to go through this case or if you want to go to discussion.
We can go to the discussion, but actually, if I could just, this will only take a minute, and illustrate the importance again of objective testing when assessing children. We were referred a 16-year-old Asian teenager after a very severe asthma attack requiring high dependency care. And when this child came to clinic, she really did report very few symptoms, and there was no concerns on her part about the chest. But she had had previous episodes of slight breathlessness here and there, and had been prescribed a blue inhaler, which she was using as needed. And if I have control of the slides, we then performed a lung function test. And this is essentially what it showed. The FEV1 of this child was 54%, and she was very clearly obstructed as well. And the key message here is that if children aren't investigated, then this kind of event gets missed. And I put this up because I can assure you this is not a one-off, and we see these types of children fairly regularly in our service and on the wards. Children, the first presentation is a very severe asthma attack because the asthma has been grumbling unrecognized for many years, and they've been undertreated. And this is just really, again, to emphasize the key importance of testing. And I think from my perspective, we can go on to the questions. Oh yeah, I had a question. Thank you, Ali, for creating. I don't know. Are we the only ones in Leicester coming across this problem? Yes. Okay. Must be a Leicester phenomenon then. Still.
Okay, so we probably come to discussion. So Ali, if you can like close the presentation. So when I look through the many comments in the chat, I just want to say two important things. So it is very difficult to put everything into this one talk. So I really would suggest that you all read the manuscript that is online. It's in a preprint version, so it's a little bit difficult to read, but you can wait a little bit until the normal structured PDF is online. What I want also to really state is these are evidence-based guidelines. So all the recommendations we do is based on the available evidence. If we are not proposing something, is because we didn't find evidence. And also we wanted to stick to measurements that are frequently available. So this is an important thing to discuss when I look through the panel discussion at the moment. So maybe there are so many points. I'm not sure whether you want to start, Errol.
Well, I have the first one. I hope it's the first one after the introductions. And Alex, it says here, underdiagnosis and overdiagnosis, but what is the gold standard criteria for diagnosis of asthma?
That's a very good point. I mean, that's what we asked ourselves at the very beginning and say, okay, what do we use as a comparator? So we included actually only data that was supported by two different objective tests. So this limited clearly the number of included papers, but we wanted to be sure that we are looking at the right papers. So there is no gold standard single test for the diagnosis of asthma. It's always a combination of one or more objective tests. I think this is important. Maybe by introducing these guidelines, we will learn about better on which test at the end is really necessary. but we think there's no one single gold standard test. It's a combination of tests.
Yeah, I would agree with that, Alex. But so the only point I guess we have made during the discussions is that universal definition of asthma is variable airflow obstruction. So some form of airways narrowing clearly hints towards the diagnosis of asthma. And whilst there isn't a gold standard test demonstrating abnormal spirometry and bronchodilator reversibility, is really a very strong hint.
Absolutely. And this comes actually just to the right. Next question is that one of the problems is that currently spirometry is difficult in the pandemic. Yes, that's clear. I mean, this is limiting not only asthma diagnosis, but many other things. However, we think that as soon as possible, spirometry should be done. And this brings me just to the next question I want to give you the discussion is, yes, spirometry is important to diagnose asthma, but frequently we see actually normal spirometry in children. So should we do diagnosis of asthma based on symptoms only in these children? And another discussion was, why shouldn't we do bronchodilator tests when children have normal spirometry?
Yeah, I think that really goes to the heart of the question. And I think we opened by saying that diagnosing asthma generally and asthma in children can be a major clinical challenge. My point here would be that performing spirometry and demonstrating normal spirometry in a child in itself is reasonably reassuring. Then the pheno will also give a hint. But again, it boils down to the question of giving a diagnosis based on clinical symptoms alone, because it's been shown that that is unreliable. So the recommendation from the task force really is to persevere. If you can't make a diagnosis at the first visit, then if the child presents with respiratory symptoms, at that point, spirometry needs to be repeated. Because in a child presenting with respiratory symptoms and completely normal spirometry, there the diagnosis probably is in doubt and further advice or further investigations are needed. That would be my answer.
So I can answer the second question is the fact, or should we do bronchodilator responsiveness testing also in children with normal spirometry? This is a very, very good question. And I can tell you that we discussed hours about this. So in many clinics, bronchodilator test is always done when you have a concave curve in eyeballing. And yes, in many children, you see a significant improvement also with normal values. And this is considered to be also associated with asthma. So it's not true only for children with reduced lung function. This is important. And it's considered clearly in the text that yes, you can perform bronchodilator responsiveness test in children with normal lung function, has the same value. But do not make the algorithm too complicated. We got rid of the arrow to that line. So
I can see a question on peak flow here next. Peak flow used at home was measurements for several days, and using bronchodilator, I guess, peak flow variability. We have a question here, how useful that is for diagnosis.
I think it's probably quite difficult to do a good instruction to do peak flow and bronchodilator responsiveness testing at home. You could consider to do this in your office and see how peak flow changes after bronchodilator. To do it at home, I mean, we have clear data that peak flow measurements are often improvised just before the clinical visit, so it's not reliable. The paper-written peak flow books are often not reliable. So we have still put the peak flow variability as a possibility for those healthcare settings, and this is also referring to further discussion points for those healthcare situations where other tests like exercise challenge tests or methacholine challenge tests are not available. So we leave this possibility, but we prefer other objective tests to be performed.
Yeah, I completely agree. And I think what we find, and this is also what's been reported by people studying this, one of the key problems, as Alex hinted to, is that sometimes these are made up. One can get around this by using electronic peak flow meters. They are probably better, and this is the only way the task force recommends using peak flow. The key with peak flow diaries is that less than half are ever returned to the clinician. They're really hard to get back. And so it's not an easy test to use for asthma diagnosis, but it is in there, and in certain circumstances, the test can be useful in the form of a 2-week diary using an electronic peak flow meter.
So I try to put together 2 questions that came up more than once. It's about thresholds. So one question is the threshold for exercise challenge 10% fall in FEV1? And the second is the question about bronchodilator responsiveness, the threshold of 12%.
Yeah, I mean, the difficulty was this 12% threshold. That really is an ongoing debate and does almost certainly need more work to basically establish what the right threshold should be in children. And the task force is aware that lower thresholds have been proposed up to 8% reversibility. And I think that wouldn't be unreasonable in the context that normal bronchodilator reversibility in healthy individuals probably is no more than 1 to 2%. And somebody clearly will feel potentially an 8% reversibility. Does it constitute asthma? It's an incredibly difficult question. This all boils down to sensitivity and specificity. I stressed earlier that there is, on this point, there is really no data in children. This has been derived from adult studies, and even those where derived from patients with COPD, asthma overlap, and it's not entirely clear, but that 12% threshold has clearly stuck. In terms of exercise reversibility, another difficult one, but some investigators have proposed 15%, and in fairness, this is the threshold we have been using here in Leicester to date. But when we carefully review the data, and please accept that these were really, the evidence was very carefully scrutinized, we agreed that 10% was probably the better threshold. We have a question here about guideline overload. I don't know, Alex, what your thoughts are. It clearly is a concern.
Yes, I agree. I mean, there are many guidelines around, but I think there is no guideline for asthma diagnosis in children yet. And so there is no overuse of guidelines at the moment for this instance. That would be my response as the chair of the task force and the last author of the manuscript. But I think, yeah, right. I mean, guidelines is not is not just something that should be used as a cooking book. It's you as a doctor and as a physician, you have a child and you have a parent, and you have to do your clinical work. And the guideline is something that may help you to decide based on the current evidence.
Thank you, Alex. Looking at the time, I think it is 6 o'clock, and this really does bring us to a close. And for me personally, I would like to thank everybody who attended this afternoon or this evening, and there's been a great discussion, and I really hope that there is good engagement with this guideline.
I also want to thank you, everybody that is in the audience, and for the lovely talks and the active discussion. I think if you look at the questions that came up and discussion points, many of them are actually covered in the manuscript. So please read it carefully, and you can also write us emails if you have certain important questions. So it was a pleasure to be here, and good evening, everybody.
Thank you.
Bye-bye.
Bye-bye.